This will be a brief lecture on just the basic facts of depression. We will cover diagnostic criteria, epidemiology, course and prognosis. In a subsequent video, etiology and treatment. If you're able to remember everything in this lecture, you shouldn't have a hard time passing the quizzes. Let's start with the criteria of depression according to DSM. Depression and anhedonia are called the cardinal symptoms because one of the two must be present to diagnose depression. You also need 4 additional symptoms from the SIGI-CAPS acronym, and these symptoms have to be present for at least 2 weeks. Now SIGI-CAPS in more detail. Sleep is one of the most common and notable symptoms of depression. Popular culture will often depict a person with depression as sleeping all the time. This would actually be considered a component of atypical depression. Typical or melancholic depression is most associated with difficulty falling asleep, and especially early morning awakening. Other patterns that are seen include multiple awakenings or hypersomnia, as mentioned earlier. Interest or anhedonia is a cardinal symptom, so make sure you don't count it twice if you're using SIGI-CAPS to count for additional symptoms. Anhedonia is basically not enjoying things you used to. This does not have to be global, as in that a person enjoys absolutely nothing. Rather, you'll see it in an avid fisherman who says he just doesn't feel like it anymore, or that it isn't the same as it used to be when he's talking about fishing. Guilt is a bit less common and harder to ask about without implicating that the person has done something wrong. If you find yourself backpedaling in the interview because the patient is getting defensive, chances are he or she is feeling guilty about something, and on the initial interview, it really isn't that important to find out exactly what it is. Low energy is extremely common, but can frequently be confused for other medical illnesses. Make sure a thorough workup of all other likely conditions has been done. Concentration is frequently an early complaint, especially amongst higher functioning individuals who tend to be very resilient and push through despite being depressed. You can see this symptom in medical and law students a lot when they are starting to get depressed. Appetite is similar to sleep in that it can be seen as an increase or a decrease. Again, popular media will depict this as a woman eating a whole gallon of ice cream after a breakup, but it is more commonly seen in the form of an unintentional weight loss due to feeling nauseated or just not hungry. Weight loss, like low energy, is another sign of a possible medical condition, so keep that differential wide open. Psychomotor is a little tricky in that it is more commonly observed by loved ones than reported. Patients will sometimes say that they feel slow or lethargic. Reports of feeling like that they have leaden feet or are carrying around a ton of bricks are common expressions. More often, family members will complain that a patient is taking forever to do something or dragging. Also, keep catatonia on the radar, and we can discuss this later. Suicide can be very intimidating to talk about, but as you'll see in future slides, it's so frequent that this is possibly one of the most meaningful ways to save lives in practice. Let's move on to epidemiology. The prevalence of depression is quite astounding. In a lifetime, 16 of 100 individuals will have depression. So in your medical school class of roughly 200, that's 32 people. Just to give some perspective, asthma has a prevalence rate of 13 in 100, and COPD in Washington, where the air is a little bit more clean, it's 4 in 100. If you look at all the depressed people in the U.S., it would be equivalent to the populations of California, the most populous state, and Michigan combined. 40 years is the average age of onset, and twice as many women have depression compared to men. These 4 men highlight the fact that 4 times as many men kill themselves as women, despite the fact that women attempt suicide more often than men. Women attempt by poisoning or overdose, while men use firearms, which explains this discrepancy. The different races and pictures of money is to help you remember that there are no differences across ethnic and socioeconomic lines. Lastly, depression makes every other medical condition worse, so even if you don't want to treat a person with depression personally, you likely will not be able to improve someone's diabetes or heart disease unless you are getting their depression addressed. So at the very least, please refer. Let's go over course and prognosis now. Here we have a sample size of 20 individuals, so each person represents roughly 5% of the population of depressed people, the 48 million above. If you took all 48 million people with depression and followed them over time, here's what would likely happen. Roughly 60% would never get treatment for their depression. That's 29 million people that don't get treated. So 40% do get treated. Of those treated, 56% get treated by a general practitioner. That means that more people with depression are treated by internists than psychiatrists. This is a real strong argument for knowing your psychiatry well. The remaining 44% are treated by mental health professionals, but that doesn't necessarily mean psychiatrists. This could include social workers, therapists, psychologists, nurse practitioners, physician's assistant, etc. What makes this story real scary is that 15% of these individuals, treated or not, will commit suicide, and there's no predicting who those individuals might be. So like we said before, average onset is 40 years old, and depression is a self-limiting illness in most individuals. That's as long as you can keep all these individuals alive. Typically, it lasts anywhere from 6 to 13 months. This story is made even more bleak by the fact that 50% of those individuals will have a recurrent depression within 2 years, treated or not. And just a quick lead into treatment, 50 to 60% of those treated will respond to antidepressant medications. So when we throw medication at depression, we're talking about less than 20% of the depressed population.